Okay, let's unpack this. We are diving into one of the really challenging but critical areas in medicine today, the pharmacologic management of heart failure. And this deep dive is specifically, a fast-track review looking at the key drug classes, the mechanisms, and those clinical pearls you absolutely need for advanced practice.
It's definitely essential because, well, the numbers are pretty stark, aren't they? Our sources, they really highlight that heart failure hits over 6 million Americans. And even now, the 5-year mortality is still hovering around 50%. So uh, the therapeutic approach we're discussing is literally life and death and quality of life, too.
Absolutely. And our mission here is crystal clear. Break down the core info from Chapter 21. We're focusing only on the evidence right there in the text. So we're not just listing drugs, right? We're digging into the why. Why these agents, how to use them properly, the monitoring, basically connecting the textbook to real-world application.
Exactly. And the goals themselves, they've really shifted over time. It's not just about feeling better day to day anymore, though that's important. The main fight now is reducing mortality and maybe most importantly, stopping at the body's own compensatory responses that actually worsen the disease, like the RAS system.
Yeah, right, that RAS system.
Yeah.
So let's start with the basics of the problem itself, the failing heart. We often talk about ejection fraction, HFrEF, and HFpEF.
Yeah, those terms define the type of failure. HFrEF, that's heart failure, with reduced ejection fraction. Think systolic failure. The heart can't squeeze effectively. Then there's HFpEF, heart failure with preserved ejection fraction. That's more of a diastolic issue. The heart muscle is stiff. It can't relax and fill properly. But, in either case, when that cardiac output drops, the body, it basically panics.
And that panic response triggers this vicious cycle we hear about.
Right.
What gets activated and why is it so bad?
Well, the body tries to compensate, right? It increases preload, increases afterload.
Right.
But the really damaging part is activating the Renin-Angiotensin-Aldosterone System, RAAS, and the Sympathetic Nervous System, the SNS. These systems cause vasoconstriction. They make the body hold onto salt and water. And over time, they actually damage the heart muscle itself through remodeling. They accelerate the failure if we don't block them.
Okay, a vicious cycle indeed. Now, before we jump straight to the drugs that block those systems, the guidelines mention some crucial prerequisites, don't they?
They do, and this is key. 2 steps before the main drug therapy. First, you absolutely have to treat the underlying cause if possible. Manage the high blood pressure, fix that leaky valve. Second, minimize anything that could make the heart failure worse. And this is huge clinical pearl. You need to look at the patient's med list, stop NSAIs, they cause fluid retention, be really careful with certain antiarrhythmics or calcium channel blockers like diltiazem or nifedipine because they can weaken the heart's contraction, that negative inotropic effect. Then you bring in the drugs.
Got it. So prerequisites handled. If blocking RAAS is central, then our first line of pharmacologic defense has to be the ACE inhibitors, right? The Angiotensin-Converting Enzyme Inhibitors.
Absolutely foundational. ACE inhibitors are first line for HFrEF, particularly when the ejection fraction is below, say, 35–40%. And importantly, even in patients who have that low EF but aren't showing symptoms yet, they reduce morbidity and mortality. They're aimed squarely at stopping the disease progression.
And the mechanism is pretty neat, stopping angiotensin RA from becoming that really potent angiotensin II.
Exactly. By blocking angiotensin II, you get vasodilation, so that lowers afterload. You get less aldosterone, meaning less sodium and water retention, which lowers preload, the overall effect.
Yeah.
Better cardiac output, improved EF, you're directly intervening in that harmful cycle.
Okay, but here's a practical challenge I see mentioned. Titration. Symptomatic improvement can take weeks, even months. How do you counsel practitioners and patients to stick with it?
You really have to hold the line. The evidence is strong. Start low, absolutely. But you must gradually titrate upwards to the target doses proven effective in the big clinical trials. Think enalapril, 20 milligrams a day. Reaching those target doses is linked to the survival benefit, even if the patient doesn't feel dramatically better right away. It's about the long game.
Okay, sticking with ACE inhibitors. Let's talk monitoring. There's the well-known dry cough.
Right. Due to bradyacinin, can be annoying, sometimes needs a switch.
And the rare but very serious angioedema. If that happens, stop the drug, obviously.
Absolutely a contraindication if they've had it before.
But the really interesting monitoring point, the one that feels a bit counterintuitive, is renal function, specifically creatinine.
Yes. This is where clinical practice gets nuanced. Because ACE inhibitors affect kidney blood flow, you must monitor BUN, creatinine, and potassium, especially potassium, as they can cause hyperkalemia. But here's the pearl. A small rise in serum creatinine, say up to 30% above the baseline. We often expect that. It's almost Well, it's seen as a sign the drug is actually working effectively at the kidney level, altering hemodynamics.
Wait, so you're saying a slight worsening of a lab value can actually be reassuring? That's definitely something a new prescriber needs to wrap their head around.
It is counterintuitive, isn't it? But yes, a rise within that 30% limit often indicates good ACE inhibition.
Hmm.
If it jumps beyond 30%, then okay, we need to reassess, maybe adjust the dose, worry about kidney injury. But that initial modest bump, it suggests the drug is doing its job, a critical distinction.
Okay. So if the patient just cannot tolerate the ACE inhibitor, usually because of that cough, then we look to the ARBs, angiotensin receptor blockers.
ARBs are the logical next step, drugs like valsartan. They work a bit differently. They block angiotensin II directly at its receptor, the AT1 receptor. The big advantage, because they don't affect bradykinin breakdown the same way, you get much less cough. But a word of caution. If the patient had angioedema with an ACE, you still need to be very careful with an ARB. There's some cross-reactivity risk.
Makes sense. And then there's the newer, really significant development in this whole RAAS modulation story. Their ARNI, sacubitril valsartan, brand name Tresto. What makes this combination such a big deal?
It's the sacubitril part that's revolutionary. Valsartan is the ARB, while blocking angiotensin II, like we just discussed. But sacubitril inhibits an enzyme called neprilysin. Neprilysin normally breaks down beneficial substances in the body, like natriuretic peptides. These peptides help reduce vascular tone and sodium retention. So, by inhibiting neprilysin, sacubitril lets these good peptides stick around longer and do their work. The Paradigm-HF trial was a landmark. It showed Entresto was significantly better than enalapril at reducing cardiovascular death and heart failure hospitalizations in HFrEF patients. It really changed the game.
A true game changer, but switching to it comes with a really critical safety step, right?
Absolutely non-negotiable, the 36-hour washout period. If you're switching a patient from an ACE inhibitor to an ARNI, you must stop the ACEI for a full 36 hours before starting the ARNI. This is crucial to minimize the risk of angioedema, which can be higher if both drugs are active at the same time. Patient education here is paramount.
Okay, huge safety point. Let's pivot now to the second major pillar of therapy, beta blockers. The sources mention a fascinating history here. They used to be a no-no in heart failure.
That's right. Historically contraindicated because they can, initially, decrease the heart's pumping strength, that negative inotropic effect. But we learn more about the pathophysiology. We realize that chronic activation of the sympathetic nervous system is a major driver of heart muscle damage and remodeling. So blocking that sympathetic drive with beta blockers is key. Specific ones, carvedilol, metoprolol, succinate, the long-acting form, and bisoprolol are now essential. They should be added to ACE inhibitors or ARNIs for basically all stable patients with HFrEF, NYHA Class II through 4. They reduce mortality from both pump failure and sudden death.
Another class where, like the ACE inhibitors, titration is everything.
Everything. You absolutely cannot start these at a high dose. You start incredibly low, like carvedilol, 3.125 milligrams twice a day, and you titrate up slowly, usually doubling the dose only every 2 weeks, sometimes even slower, based entirely on how the patient tolerates it. Going too fast risks worsening heart failure symptoms or causing too much vasodilation, like dizziness or fatigue. Slow and steady wins the race here.
Got it. Slow and steady. Now let's talk about managing fluid volume. If a patient comes in with crackles in their lungs, swollen ankles, JVD, we need diuretics, usually loop diuretics.
Immediately. If there are signs of volume overload, diuretics are added right alongside the ACE or ARNI and beta blocker. They work by increasing salt and water excretion, which decreases preload the volume returning to the heart. Loop diuretics like furosemide are generally the go-to because they're more potent. But the real clinical pearl with diuretics isn't just the drug choice, it's the monitoring.
How so? What's the key?
Daily weights. It sounds simple, but it's one of the most effective tools we have. The patient needs to weigh themselves every single morning, same time, same scale, before breakfast. A sudden weight gain, like 2-3 pounds overnight or 5 pounds in a week, is often the first sign of fluid retention. Reporting that promptly allows for diuretic dose adjustments and can often prevent a hospital admission. It empowers the patient.
That makes perfect sense. And staying with volume and hormonal effects, what about spironolactone, the aldosterone antagonist? It's more than just a diuretic, right?
Much more. Spironolactone is specifically recommended for patients with NYHA Class II to IV HFpEF and an LVEF of 35% or less, based on studies like RAAS showing it reduces morbidity and mortality. It blocks aldosterone's harmful effects on sodium retention and fibrosis. But here's the monitoring challenge again. Spironolactone spares potassium, And since patients are usually also on an ACE inhibitor, or ARB, or ARNI, which also scare potassium.
So double potassium sparing effect. Risk of hyperkalemia.
Exactly. You have to monitor potassium levels very closely. And creatinine, too, generally. Guidelines suggest keeping creatinine below about 2.5 milli-GDL in men, for instance, when using spironolactone.
Okay. One more classic drug to touch on, digoxin. Where does this cardiac glycoside fit into the modern picture?
Digoxin's role has definitely evolved. Its mechanism involves inhibiting the sodium-potassium ATPase pump, leading to increased intracellular calcium, which gives a mild positive inotropic effect, a slight boost in contractility. It's been shown to improve symptoms and decrease hospitalizations for heart failure. But, and this is the crucial takeaway, it does not decrease mortality. So it's generally used as an add-on therapy for persistent symptoms, despite optimal ARNI and beta blocker use, or maybe if there's a second reason, like needing rate control for coexisting atrial fibrillation.
And it's famous, or maybe infamous, for its narrow therapeutic window.
Extremely narrow. The target serum level for heart failure benefit is quite low, typically 0.5 to zero point 0.9 nanograms per milliliter. Toxicity is a real concern, and the symptoms are tricky because they can be non-specific, not just heart rhythm problems, but also things like loss of appetite, nausea, confusion, and even classic visual changes, seeing yellow halos or blurred vision. You have to be vigilant.
Okay, so we've covered the foundational ACEs, ARBs, ARNIs, the essential beta blockers, and the volume managers like diuretics and spironolactone plus digoxin. What about more targeted therapies for specific situations, like hydralazine combined with isosorbide dinitrate?
Right, the HYD-ISDN combination. This is a balanced vasodilator. Isosorbide dinitrate is primarily a venodilator, reducing preload. Hydralazine is an arteriolar dilator, reducing afterload. It has a couple of specific niches. It's an option for patients who truly cannot tolerate ACE inhibitors or ARBs, maybe because of significant kidney problems or intractable side effects. But importantly, it has a specific recommendation based on the AHF trial for African-American patients with NYHA Class II or 5e HFrEF who are already on optimal therapy, including ACE-ARB and beta blockers. It showed a mortality benefit in that population.
Interesting specificity there. And then there's a relatively newer agent, ivabradine or Corlinor. How does that fit in?
Ivabradine has a really unique mechanism. It selectively inhibits what's called the IF current, the funny current, specifically in the heart's sinus node. The net effect is it slows the heart rate down without affecting the force of contraction or blood pressure, unlike beta blockers. So its indication is for patients with symptomatic, stable, chronic HFrEF who have an LVEF of 35% or less, are in normal sinus rhythm, and have a resting heart rate of 70 beats per minute or higher despite being on the maximum tolerated dose of a beta blocker, or if they have a contraindication to beta blockers. It's about getting that heart rate down when beta blockers alone aren't enough or can't be used.
Okay, that makes sense. So pulling all these pieces together, the foundational drugs, the add-ons, the specific targeted agents, can you sort of synthesize that modern treatment approach, maybe like the three-tier framework mentioned in the text?
Sure. Think of it as a staged approach, guided by evidence. Tier 1. You start with foundational neurohormonal blockade, an ACE inhibitor or an ARB, or increasingly an ARNI is preferred if appropriate. You'd add a diuretic here if the patient has signs of fluid overload. Tier 2. Once the patient is stable on Tier 1, you add the evidence-based beta blocker, starting low and titrating slowly as we discussed. Tier 3. This is where you tailor further based on remaining symptoms and specific patient factors. You'd consider adding an aldosterone antagonist like spironolactone if they meet criteria, NYHA LVEF 35%. If symptoms persist, you might consider digoxin. Or, based on specifics like race or intolerance, you might use HYD-ISDN. Or if the heart rate is still high despite max beta blockade, you consider ivabradine. It's a stepwise optimization.
That's a really helpful framework. And throughout all this, patient education seems absolutely critical, things like sodium restriction.
Crucial. Generally aiming for 2-3 grams of sodium per day. Limiting alcohol, quitting smoking, those lifestyle pieces are non-negotiable.
And drug-specific warnings, too, right? Like the teratogenicity.
Yes, ACE inhibitors, ARBs, ARNIs, even ivabradine that are contraindicated in pregnancy. Huge counseling point. Patients need to know to stop immediately if pregnancy occurs or is planned. Also, educating about recognizing angioedema symptoms and reinforcing that daily weight tracking we talked about that's key for diuretic management and self-monitoring.
This deep dive really underscores that massive shift in thinking, doesn't it? From just propping up a failing pump to this multi-pronged strategy attacking the underlying neurohormonal chaos, we've covered the absolute necessity of careful titration for those RAAS inhibitors and beta blockers, the importance of volume control, and those critical safety points like the ARNI washout.
It really has evolved. And, this brings up a really important point for you, the advanced practitioner listening. Considering just how complex this titration process is, that whole start low, go slow mantra, and knowing that things like non-compliance can be challenges, especially maybe in older patients, how absolutely vital is that continuous real-time feedback loop? Things like the patient reporting daily weights, calling about symptoms promptly. How critical is that connection in bridging the gap between our pharmacologic knowledge, all these drugs and tiers we've discussed, and actually achieving successful long-term outcomes out there in practice? Because that partnership, that feedback, that's often what makes or breaks therapy.
That's a powerful thought. That active partnership between the clinician and the patient truly seems to be where these incredible but complex medications really prove their life-saving potential. Well, that wraps up this essential deep dive into the pharmacologic management of heart failure, based strictly on the insights from Chapter 21. Thank you so much for joining us for this review.
Yes, thank you for tuning in and for your commitment to mastering this vital area of practice. From the Last Minute Lecture team, we appreciate you being here.